Okay, everyone. Thank you so much for joining the session today. I see we are at about 27 participants. So while there are others that might be joining now, I think we're going to get started because we have a full session for you today. Good morning, good evening, good afternoon for those of you joining from all over the world. And really welcome to today's session on improving accountability of community-based child health services in Northern Nigeria, community health pharmacists, and information services on behalf of the Child Health Task Force, as well as USAID. I just wanted to mention that I'm Malia Boggs from USAID and also a member of the steering committee of the Child Health Task Force. And we are really thrilled that you are joining us for this 2-day virtual conference. So I will not say much other than I'm going to now hand the session over to our moderator, Angie Steen, a director of health at Palladium and one of the headquarters directors on the Integrated Health Program in DC. She has backstopped the Integrated Health Program in Nigeria since it started in 2019, working most intensively on child health, nutrition, and community-based work. So with that, again, you're really in for a treat today. I'm going to turn it over to Angie to get us started. Thank you.
Hi, everyone. Thank you so much for joining us for our presentation. We are really proud to present some of the work that the Integrated Health Project, supported by USAID, is doing in Nigeria, particularly 3 states in northern Nigeria. So the title of our presentation is Improving Accountability of Community-Based Child Health Services in Northern Nigeria, with a focus on community health pharmacists. You'll hear the acronym a lot: patent proprietary medical vendors, which are PPMVs, as well as community pharmacists, and the community health information systems, which is brand new in Nigeria. So I'm going to be introducing our speakers. We've got a panel of 3 speakers, all of whom work full-time on the IHP project. And then I'll also be providing a quick overview of IHP. So our presenters are Dr. Zainab Mohammed, and she's a medical doctor with 15 years of experience executing public health programs. She holds a master's degree in public health and currently serves as one of our very talented primary healthcare advisors in Sokoto State on IHP. Prior to joining IHP, Dr. Mohammed worked for various USAID health projects in Nigeria, including the USAID Immunization Basics Project and the USAID Targeted States Health Impact Project, TSHIP. And she's also consulted for the Bill and Melinda Gates Foundation. For over 15 years, she's provided strategic leadership for improved service delivery, governance, and civil society engagement programs in Nigeria. Our second panelist is Tosin Harold Akinbemisolu, and he is our dedicated data manager and data scientist on the project. He's got over a decade of experience building digital health solutions in various sectors, mostly in the international development sector. He's got a bachelor's degree in chemistry and an MBA from the University of South Wales in the UK. He also has a master's in data science from the University of East London. He's a certified data scientist by Microsoft. Interestingly, he's about to go to Canada to get his PhD in AI and data science, which is very, very exciting. Although we are going to miss him because he's provided a ton of expertise on developing analytical tools for IHP and also the government in Nigeria. Dr. Chinwoke Isiguzo. She is our director of MEL on the HQ or headquarters side. She works very closely with Dr. Jumoke, who's our key personnel or MEL person in Abuja. Dr. Chinwoke's work focuses on designing and evaluating innovative interventions that foster health behavior change, increase access to maternal child health, malaria, and nutrition services. And she works a lot on improving health service delivery through community-based platforms. She also is probably one of Nigeria's foremost published authors on PPMVs. So we're really excited to have her on our project and also on this panel. But Chinwoke also just finished her PhD at the University of Pittsburgh in Pennsylvania, where she focused on racial equity-focused breastfeeding research. And she's also done a lot of research in Nigeria on the ICCM, or Integrated Community Case Management of Childhood Illnesses Protocol or strategy in Nigeria. She provides technical direction and support on MNCH, monitoring, evaluation, and learning. And as Malia mentioned, I'm one of the directors here in HQ, helping to backstop the IHP project. So with that, I'm going to provide a quick overview of our project. So again, USAID funds the very large and complex IHP project. We operate in 5 states, as you can see on the map, but the states that we're going to really focus in on today are Bauchi, Sokoto, and Kebbi, which is where we've been engaging PPMVs and utilizing the CHMIS system to monitor performance of those PPMVs and improve that performance and quality of care. Our reach is approximately 1,140 PHCs, primary healthcare facilities, 99 general hospitals, and we reach approximately 1,100 community pharmacists and PPMVs. Our reach is 4.8 million women of reproductive age, as well as children under 5. It's our targeted group, though we do also work extensively on male engagement as well. So with that, I'm going to be handing this over to, oh, excuse me, one more slide. I should say we also focus, IHP also focuses on all the health system strengthening blocks. So health finance, leadership, government, advocacy, commodities, data, as well as access and utilization. So linkages to communities, which is also a big part of why we're engaging PPMVs. And then we also focus on RMNCH plus NM. So maternal, newborn, child, adolescent, reproductive health, family planning, nutrition, malaria. And we have cross-cutting work in gender and social inclusion, private sector engagement, innovation, and technology. So with that, I'm handing it over to my colleague, Dr. Zainab, who's going to tell you about the relevance of the PPMV approach and our methodology in engaging these important frontline actors. Dr. Zainab.
Thank you very much, Andy. So what are PPMV's relevance for child health equity and service delivery? In Nigeria, the patent and proprietary medicine vendors are the primary source of medicines for treatment of common childhood illnesses. That's in addition to selling drugs, especially in rural areas. And there is also an estimated 200,000 PPMVs currently operating in our country. While the PPMVs provide healthcare services, we realize there is only small amounts, that is one percentage, about 10 to 15% are registered or licensed by the Pharmacists Council of Nigeria, which is the regulatory body for both the PPMVs and the community pharmacies. And also, just small amount have received some training and supervision as part of the licensing process. We conducted a program, private sector landscaping assessments. And what we found that in these 3 states, that's Bauchi, Kebbi, and Sokoto, there are only 1,320 registered PPMVs and 8,150 unregistered PPMVs across the 3 states. While the national survey shows that PPMVs are the actual first source of care for the children under 5, about 54% cases of treatment of fever, 50% cases of diarrhea, and 40% cases of acute respiratory infection occurring among children under 5 years. And the National Tax Shifting and Tax Sharing Policy issued in 2014 calls for capacity building of community-oriented resource persons, which include the community health influencers, promoters, and services, as well as the PPMVs and community pharmacists, among others, to provide treatments, counseling, as well as referral for some health, child health services, reproductive health, and other healthcare services. So these policies represent a major step towards addressing the shortage of health workers needed to deliver essential health services in our health facilities, especially in the community that is underserved, as well as often low resource. Prior to IHP, that's integrated health program intervention, and also the role of community health information system in Nigeria. PPMVs in Nigeria in these 3 states had no accountability mechanism, while quality of care and services provided by these bodies are not documented. The introduction of this CHMIS has been a game changer to promote accountability, monitoring, and mentoring opportunities for these 3 states of Nigeria. At this point, I would like to hand over to my colleague Tosin to take us through the Community Health Management Information System, how it is used, and why is it critical for the Nigerian health system. Thank you.
Yeah, thank you very much, Dr. Zainab, and good day, everyone. So like Dr. Zainab said, I would start by talking to you about the Community Health Information System and its significance in capturing service delivery data. And so firstly, what exactly is the CHMIS? So CHMIS generally goes beyond a mere data system. It encompasses a range of processes and mechanisms that generate health-related data at the community level. So the aim is to make this data accessible to users, both within and outside the health sector through effective networking, thereby ensuring its availability for decision-making and planning. And why is the CHMIS critical for capturing service delivery data? One crucial aspect is its capacity to collect, collate, aggregate, analyze, and archive health-related data that may not be readily available at traditional health facilities. So we often encounter situations where valuable data is obtained from informal service providers outside the orthodox health service. So CHMIS bridges this gap by capturing and organizing such data, providing a more comprehensive picture of the overall health situation in the community. In terms of entry of data into the CHMIS, we have 2 key groups involved. So the first group is known as the CHIMS, community health influencers and promoters, and they play a vital role in the community, promoting health awareness, delivering basic health services, and acting as a liaison between the community and formal health systems. And then the second group, which is the PPMVs, CPs, like Dr. Zainab mentioned, that non-formal health providers who often dispense medications and offer healthcare services within the community. So these 2 groups are both instrumental in entering data into the CHMIS since they're embedded in the community, ensuring that valuable information reaches the system. So now we shift our focus a bit to the key child health indicators captured by the CHMIS. So several key cases and interventions are tracked to ensure that the necessary treatments and referrals are provided for monitoring the health and well-being of children in the community. So and such few examples are monitoring the cases of diarrhea, ensuring that ORS and zinc treatments are administered, cases of fever, specifically using MRDT screening and treating positive cases accordingly, monitoring of respiratory conditions, and provision of amoxicillin DT treatment when necessary. And then nutrition, which includes the screening for mid-upper arm circumference and referral of cases for MAM and SAM cases for further intervention. And then lastly, we also have the referrals for antenatal care and postnatal care, which are also captured, ensuring that pregnant women and new mothers receive the appropriate healthcare support. Next slide, please. So here we discuss how USAID integrated health program has supported the CHMIS by providing various forms of assistance and training. And so to begin with, IHP has collaborated with the Federal Ministry of Health to conduct training on relevant data tools and instruments. So this collaborative effort aims to equip the relevant stakeholders with the necessary skills and knowledge to effectively utilize the system. IHP has also played a significant role in supporting the optimization of DHIS2, which is a software platform used as the National Health Management Information System, where the CHMIS is also linked. So this support involves activities such as configuring data elements, validation rules, and other relevant components of the system, specifically focusing on the version released in 2019. And so in a nutshell, by optimizing DHIS2, IHP has helped to streamline data management processes and enhance the overall functionality and accuracy of the CHMIS. Another important aspect of IHP support is related to health data governance and health data consultative meetings. So these initiatives actually has helped to facilitate discussions and collaborations among various stakeholders involved in the CHMIS implementation. So by fostering this consultative approach, IHP ensures that decision-making processes are inclusive and that the data governance framework aligns with the needs and priorities of the community. Additionally, IHP provides technical assistance in the development of data tools specific to the CHMIS. So this support involves helping to design and implement data collection instruments that are tailored to the unique requirements of the community health context. And then we also, IHP has also contributed to the continuous improvement of data quality, which is of course ongoing within the overall health management information system. And this support includes activities such as the DQA data quality assessment, implementation of integrated supportive supervision and mentoring visits. And through these visits, IHP collaborates with local stakeholders to review and address quality issues, data quality issues. And by identifying areas for improvement and providing guidance, IHP has helped to enhance the reliability and validity of the data collected through the system. So I'll now hand over back to Dr. Zainab to take the next few slides. Thank you.
Thank you, Tosin. So what are our engagement strategies? First, we signed a memorandum of understanding with the Pharmacists Council of Nigeria, which is the agency responsible for licensing, regulating both the PPMVs and retail pharmacies. We also, for health system strengthening and also to ensure continuity, we collaborated with state government, that is State Ministry of Health, the State Primary Healthcare Development Agency, the local government authorities, and the professional associations of the PPMVs and CPs, that's Association of Community Pharmacists of Nigeria, ACPN, the National Association of Patent and Proprietary Medicine Dealers, that's NAPMED, as well as our implementing partners in the states. These associations, we engage them and they were for them to provide oversight function and also coordinate the activities of the PPMVs and CPs. Next slide. The selection of the PPMVs, they were selected by the Pharmacists Council of Nigeria, that is the PCN, in collaboration with the State Ministry of Health and IHP, based on a set criteria. We first look at the compliance with the country regulation, that's if they are registered as well as licensed by the PCN. We also look at their educational qualification. At least they should be able to read and write, and also at least secondary school certificates indicating basic literacy and numeracy for them to be able to assimilate the basic skills we are going to train them, as well as be able to use the CHMIS tool and document the services being provided. We also look at their location, and we give priority on locations within underserved communities. So on the training, using the adult principal learning and competency-based training approach, we enhance the capacity of 1,114 PPMVs and CPs, which is distributed across the states. And this number we train across 1,092 outlets. The training was on timely identification and management of uncomplicated childhood illnesses, which include malaria, pneumonia, diarrhea, nutrition screening, as well as referral services based on this ICCM guidelines, that's Integrated Case Management Guidelines. We train more than one person in the community pharmacy shops, because we realize that most of them, the community pharmacies, they don't stay. So we train additional 22 pharmacist attendants so that the services will continue even when the community pharmacists are away. The training was done in collaboration with the State Ministry of Health, the State Primary Healthcare Development Agency, the local government authorities, the PCN, and also the Professional Association of the PPMVs, that's the NAPMED, as well as the ACPN, who we engage to provide oversight function and also ensure adherence to protocols. What did we use for the training? We used the approved revised training manual, PCN manual, which is the mandatory entry point training program for Tier 1 PPMVs, and also the PCN approved training slides for community pharmacists. In addition to that, we also use the National Integrated Case Management Guidelines and SOPs, that is the ICCM chart booklets, as well as the 6-chart recording forms. As you can see on the left side, the chart is showing the number of PPMVs and CPs that we train per state across the 3 states. And the training was conducted within a period of 6 weeks, from August through September, and it was in clusters of about 15 to 25 PPMVs per cluster, with each cluster with like 5 to 6 clusters running concurrently and facilitated by at least 3 and 4 facilitators. The regulatory aspect of the training was facilitated by state PCN staffs. So prior to the training of the PPMVs and CPs, what did we do? We collaborated with the Federal Ministry of Health and engage the national ICCM trainers. We held a central 2-day standardization meeting with the selected trainers and PCN to discuss and agree on best modalities and approach to deliver the training. Then we also conducted a training of trainers at the state level. So it's the trainers that step down the training to the PPMVs as well as the CPs at the state level. We provided them with basic tools like the audible timers, digital thermometers, mean upper arm circumference tape, among others, as well as the training manuals, the CHMIS tools, and job aids, which include this, the chat booklet, ICCM chat booklets, and also some other job aids they were referring while they are counseling the clients. For us to ensure that quality of service provided, we commence regular on-site mentoring on service provision, as well as documentation, ensuring documentation immediately into the data tools. That's immediately after the training, and it's still ongoing. We also encourage service data documentation and collection using the CHMIS tool. So far, currently, about 92% of the trained PPMVs and CPs are reporting using the CHMIS tool. You can see that from the chart on the right side of the presentation. When we started, because the training was in clusters and in phases, the first that were trained started reporting, and that's how continuously till it keep on improving up to the last batch of training. So for us to enhance skill retention and ensure that the PPMVs and CPs are providing quality services, we collaborated with our consortium partner, Viamo, who developed a digital job aid that is accessible by the PPMVs and CPs through their phones in different languages to promote quality of care and appropriate care for childhood illnesses. Next slide. So how do we ensure quality improvements among the PPMVs and CP service provision? IHP works through local partners, that's via grants under contract, to provide regular on-the-job training and supervision to improve quality of services provision and data documentation and collection using the National Adapted ICCM Mentoring Checklist. Our routine mentoring include problem-solving support to the PPMVs, review of the ICCM tools and CHMIS data capturing tools, and also the athlete performance review. And the trained mentors were assigned to a cluster of about 14 to 20 athletes, depending on the proximity as well as the locations, to conduct at least 2 to 3 visits monthly per outlet. We also conducted monthly review meetings with the mentors and stakeholders for us to discuss challenges, lessons learned, as well as solutions. A joint monthly mentoring and supervision were also carried out by the grantee and the stakeholders, that's the State Ministry of Health, the PCN, the NAPMED, ACPN, partners, to ensure effective service delivery and data compliance. So I'll be taking us through our integrated mentoring checklist. Furthermore, to ensure quality of care and also make sure that the PPMVs and CPs adherence to the guidelines and protocols, we adopted, as I mentioned earlier, we adopted a national ICCM mentoring checklist to serve as a guide and for use by mentors and supervisors during the visits to the outlets. As you can see on the right side, a snapshot of the checklist. So on the checklist, it contains the child health elements of the mentoring, which focus mainly on the integrated community case management. You can find the link on the last slide. We also make observation on the case management of childhood illnesses, evaluation of danger signs, which include convulsion, reported or observed, unconsciousness, vomiting everything, inability to eat, or drink. We look at the cough or respiratory illness, also the section of diarrhea, fever, malnutrition. We also observe and evaluate to determine appropriateness of care they are providing. On data quality, we ensure that there's appropriate completion of sick-care recording form, the CHMIS, which include the service registers, the referral forms, and the monthly summary form. We check their commodity and supplies availability and appropriate use based on the information received and as well as decision made. If you look at the next slide, that is slide 11, is additional snapshot of the mentoring checklist, which you can find on the last slide of the presentation. So I will now hand over to my colleague Tosin to share with us our achievements so far. Thank you.
Thank you once again, Dr. Zainab. So we'll quickly discuss the results achieved through the Community Health Information System implementation, which basically highlights the impact and effectiveness of the system in capturing and utilizing community health data. And so in the first 9 months of operation, an impressive progress was made in terms of reporting, with 92% of the enrolled PPMVs and CPs reporting into the system. So this high reporting rate indicates a strong engagement and commitment from these non-formal health providers in contributing data to the CHMIS. Regarding child health indicators, over 117,000 children presented with fever, and 7% of them were diagnosed using malaria rapid diagnostic tools, that's MRDT. And that also demonstrates at least a successful integration of malaria testing in the CHMIS workflow. Additionally, 97% of tested and confirmed cases of uncomplicated malaria received appropriate treatment with ACTs, which equally underscored the effectiveness in ensuring timely diagnosis and treatment for children with malaria. And that's a critical step, of course, in reducing child morbidity and mortality associated with the disease. And furthermore, within the reporting period, over 21,000 children aged 6 to 59 months were assessed for nutrition status using the MOHAC, and of these, 1,541 were identified as having severe acute malnutrition or moderate acute malnutrition, and were referred for additional nutrition services, demonstrating the system's ability to at least identify at-risk children and facilitate appropriate referrals for intervention and support as needed. And then coming to child diarrhea cases, the CHMI has recorded 25,934 cases. And among these cases, 76% were treated with ORS and zinc. And so we realize this is not what we want in terms of quality of care of diarrhea cases, but this, at least having a system, gives us a chance through the CHMIS to track this issue and work to improve this over time. But however, 3,380 cases were referred, suggesting a need for improvement in the referral process. And so these findings generally have been able to highlight areas for further attention and intervention to ensure a higher proportion of improved quality of care and then referred cases as well. And the CHMI has also successfully addressed the collection of data for respiratory symptoms in children, with 94% of the cases treated with antibiotics. And then, of course, we also have the aspect of reproductive health, with CHMI facilitating provision of family planning services with a total of 29,048 women counseled on various FP methods, and 3,415 of them referred to facilities for further support. And then lastly, CHMIS also, in the CHMIS, we were able to get total of 7,408 new ANC clients identified, and 4,752 first-time referrals were made. And so this result highlights the CHMIS contribution to promoting early and comprehensive ANC services, and then at least getting this data to be able to make informed decisions as much as possible. And so moving over to the next slide, this basically still gives us this graph, and the one on the next slide as well display how reporting improved over time since when IHP started the training of the PPMVs and CPs in August. So it typically shows pneumonia, malaria, and diarrhea cases and treatment trend, which we talked about in the earlier results, and the quality of care aspect as well, which we also talked about. However, one key thing we can see is the enthusiasm in reporting immediately after the training was done. But then again, this has also shown slight decline in the past few months, which I believe my colleague, Dr. Chinwoke, will also discuss more on some of the courses and the way forward to sustain that enthusiasm of the PPMVs and CPs towards reporting into the CHMIS. And so now I'll hand over back to Dr. Zainab to talk to us on the lessons learned. Thank you.
Thank you, Tosin. So what have we learned within the period of implementation? We've learned that PPMVs and CPs need to be engaged more and continuously so that they'll be able to see the value of reporting service provided in their outlets. We observed that as my colleague mentioned, and also how the trend of our data that is showing. Initially, we observed that there was a spike in the reporting. Then after some time, there was a drop. And as you mentioned earlier, it's due to initial excitement because this is something new. They have not been documenting the services being provided. And now when they started, it was something new. They are so excited and they were reporting appropriately. And later this fell. Also, given at their geographic spread and accessibility, we learned that they are an important opportunity to increase access as well as high quality healthcare services for child health, as well as underserved communities. We also learned that there's need to factor a short and easily replicable training and mentoring methods due to high attrition and turnover of the PPMVs and CPs. This is one of the things that we observed. The number that we've started reporting is dropping, even though not much, but there's a need to factor in how to mentor those that are coming up as when some are dropping. We also learned that training and provision of regular on-site mentoring and supervision, it improved the skills and quality of service delivery provided by these PPMVs and CPs, as well as documentation. Because initially, when they started the reporting, we observed a lot of errors. And as we continue mentoring them and providing oversight, we observed some improvements. We also learned that linking the PPMVs and CPs to the primary healthcare centers can improve referral, which they are referring. We've seen an increase in referral from the community, which is actually in some of the states, it's not happening. But from the engagement and the training and mentoring and supervision of these PPMVs, we have observed some referrals coming from the community, to the health facilities. In collaboration with PKM and local manufacturers, as well as the government drug management agencies, our collaboration had helped us to improve PPMVs and CPs access to quality medicines. And we also collaborated with these stakeholders on drug supply, training, and monitoring of PPMVs. So this joint supervision, we've learned that when this is happening, it can actually improve the regulatory compliance and service quality provided by the PPMVs and CPs. Next slide. Our recommendations, we recommend that PPMVs and CPs should be recognized as integral parts of the primary healthcare structure. The health system should create an enabling environment for them to be able to perform their role effectively. And CHMIS allows for closer monitoring and engagement of previous unmonitored PPMVs. PCN and other authorities can utilize the CHMIS data that's currently being collected to scale and monitor mentoring to further improve accountability of quality care and identify and plan and prioritize PPMVs and CPs engagements. The government should recognize and distinguish PPMVs and CPs that have already gone through the training and also they are providing data through the CHMIS as model providers among their peers, because that will encourage them to do more. We also recommend the incentive package from the government, such as loans, bulk purchasing of drugs, and recognition for those that are participating in reporting through the CHMIS in order to retain their interests and continuous reporting, as well as encouraging them to register and update their license on an annual basis. We also recommend the government to share results with PCN and the Pharmacy of Health for them to use and shape the currently existing policies. At this point, I would like to hand over to my colleague, Tunwoke Esibuzo, to wrap up this presentation with high-level implication of CHMIS to Nigerian health system. Thank you.
Thank you very much, Dr. Zainab, for Tosin for this wonderful presentation. And there are several proof of concepts that you can train and support PPMVs to diagnose and treat children. We can't really overemphasize the need to have a functional CHMIS system in order to optimize the role that PPMVs provide by giving health services or providing health services in hard-to-reach areas, especially in the northern parts of Nigeria. We also have a very great example, such as the ADO project in Tanzania. And from that project, there are several lessons that we've learned. We've learned from that project that PPMVs contribute, like the data that they provide has helped the supervision and inspection teams to review and assess their performance, as well as the shop's compliance to regulations. And also the records they also provide has also helped health officials to quickly identify problems such as epidemics and also provide surveillance information on common conditions in the community. So one of the things that we achieved in this project, or we're trying to show, is that the PPMVs can use the CHMIS tool, even this new CHMIS tool. And in Nigeria, while we're excited to see the enormous work that partners and the Federal Ministry of Health have done and have been doing in the past 10 to 15 years, there are several things that should be done and several things that should be put in place for this to be sustained, for this project to be optimized, and for us to also see some of the benefits of having PPMVs record data. And that brings us to the question of what next? What next? Currently, the CHMIS tools are ready, and we've piloted them across our 3 states with the PPMVs, and the Federal Ministry of Health is also piloting it, but the pilot is mostly among the community health workers. And that brings us to the issue of integration. If you had looked at some of our data, you would observe that most of the data sources are from the ODK system, which means that the CHMIS system that we're running hasn't been fully integrated into the community DHIS system of the Federal Ministry of Health. And there is that need to speed up this process of integrating the CHMIS data collected at the PPMV shops into the DHIS system. And hopefully this 1-year pilot, we're going to be contributing a lot of our lessons learned into the whole implementation structure, so that when it is rolled out, this would be rolled out also among the PPMVs. And another thing that, another question or another area that the government would need to look into is the area of supervision. There is that need to have a sustainable supervision model. I think I've been seeing a couple of questions about sustainability in the chat. Possibly we should have like a hub and spoke model where we have community pharmacists or any other cadre of health workers assigned clusters of PPMVs to be supervised. Currently, we're using a grantee, and we have mentors who go around, who go to supervise what the PPMVs are doing. But we know that this is not sustainable. And this is also something that we have seen in other programs that have shown proof of concept in Nigeria. Once the donor leaves, the PPMVs are left unsupervised. So this is something that the government, the PCN, should also look into. I know that currently the PCN is also looking at adopting some of the lessons learned from the ADO project in Tanzania by creating accreditation systems where this kind of model supervision would be implemented among the PPMVs, but there is a need to sustain that. There is a need to roll that out. And another thing that we learned, and another thing that the government should also look into, is the motivation and retention of the PPMVs. Currently, what we're seeing in the field is that the PPMVs are already asking questions. What is in this for them? What is in this for us? That initial excitement during the early stages of the project, we see them recording, filling out their forms, but 6 months down the line, there is that spike, that downward spike regarding recording of data. And this is because they have not seen the need to keep records of the clients who come to them. And this is where there should be that institutionalization of data collection among this cadre of health providers. It could be by requiring, or having policies that would mandate them to report, to maintain their licenses. It could also be like having annual refresher trainings that would also be necessary for their licensing. So these are some of the things that we hope that the Federal Ministry of Health would do as we continue advocacy to them, to just ensure that the PPMVs are well integrated into the CHMIS system. Currently, the whole efforts around the CHMIS system is around the community health workers. There is that need to also have these cadre of health providers integrated into the system, because we have seen their role in the community. We have seen that they are like one of the primary source of care, especially in Nigeria and in rural areas. So we hope to see government focus on them. We hope to see even some of their regulating agencies like the Pharmaceutical Council of Nigeria and the NAPMED, which is the governing body for the PPMVs, join forces to just see that this the rollout of CHMIS among this cadre is sustained and actually optimized. And I'll hand it over to my colleague Angie for her to take us through the questions that people have also put in the chat. Thank you.
Thank you. Thanks, everyone. Thanks, Toast and Dr. Zainab and Dr. Chinwoke for that. That's very useful. So we have 15 minutes left for questions. There are already about 5 or so in the chat. So I'm just going to read or summarize these questions, and I'm going to open it up to any of our panelists to speak on these. If anybody else has any other questions, please put them in the chat. That's probably most efficient, given there's 14 minutes left. So the first question is from somebody named RS. So how do you plan to sustain trained providers in the community? Do they move on to other work or activities? If so, how do you ensure that there are a sustained supply of these trained providers? What are the cost or resource implications of turnover? Would anybody like to take this?
Yeah, I would like to take that. And it's part of some of the things that I mentioned. This is a huge problem. It's a gap. But we have seen where these things work, right? The ADO project is a perfect example. In Tanzania, they have done that. In Uganda, they have done that, where we have accreditation system where the retail or medicine vendors are very much integrated into the health system. And we see governments taking care of some of the things that you talked about, refresher trainings, and even just having the government just take control of these things. What we're seeing currently in Nigeria is that most of these projects are being funded by donors, and a lot of times when the donors leave, the project just dies. The only good thing is that we still have some of those trained PPMVs, but we hope that the system that the government is currently developing, that's the Pharmaceutical Council of Nigeria, would also help this, because they are trying to, with the support of Bill and Melinda Gates, they are trying to also implement the accreditation system, where every PPMV in Nigeria goes through this accreditation system. What it also means is that they would also go through, like refresher trainings, which should be part of their licensing and so on. I think that's the way out. The government needs to be involved for this to be sustainable.
Thanks, Chinwoke. I'm going to move on to the next question. So from Michael, IHP builds on the USAID funded MCSP project in Ebony, particularly the EQUIP project. And Michael's asking if the EQUIP project is still sustained or still functional. We don't have any of our staff members from Ebony on the line right now, but I'm just wondering if anybody knows, Dr. Zainab or Tosin or even Chinwoke, do you know if we can speak to sort of the legacy of the EQUIP project in Ebony? I mean, I can quickly say that this intervention focused in the north. So our PPMV engagement did not include Ebony, but Chinwoke, go ahead.
It still boils down to what we're saying. So the thing is that when you go to Ebony now, you would still see those PPMVs that were trained. We hope that, like the training, they retained some of the knowledge, right? But in terms of data collection, once the project leaves, we don't see them recording the clients who come to them. And we just totally lose the information coming from those shops. But in terms of having them, they are still stationed. And that is why it is important to train the PPMVs. Once you train them, they are there, they are part of the community. So they have the knowledge, they are able to support in diagnosing and treating children. But the other aspects of that program, when it comes to supervision, I don't think they will be supervised. I don't think the mentoring is happening. I don't think the data collection is happening in those places, but they would still be providing treatment or diagnosis and treatment to their clients that come to them.
Okay, great. Michael is also saying the results are impressive, but can we compare these results to a baseline? Was a QOC assessment conducted? Was a quality of care assessment conducted before the interventions? Chinwoke, I think so. You know what was going on probably more than us, because you were involved. You've been involved in PPMV research for far before IHP came on board. Could you speak to that?
I kind of think this question is specific to a project. So we did not conduct the quality of care assessment before our intervention, but along the line, we introduced this mentoring tool, which hopefully would also look at our data to see with each mentoring session whether the quality of care that they provide has improved. So it's something that we plan to look at, and that was why we introduced that structured quality of care assessment tool in the project. So hopefully along the line, we would look at that data to see how over time they have improved based on the mentoring sessions that they have been receiving. So we can also choose a particular baseline, at the beginning of the project, or once the mentoring tool was introduced, and look at it over time, how the quality of care or the quality of care that they provide has improved.
Okay, thanks. And this next one, Tosin, maybe you can take a stab at this next one. So does the CHMIS application just capture data from the PPMVs, or do they use it while assessing and treating the clients?
Okay, thank you, Angie. So currently, just like Chinwoke said, the CHMIS application we built was more like an in-out for us to be able to learn through the process, while still supporting the government to integrate the CHMIS into DHIS. And so as it is, the CHMIS currently being reported by the PPMVs and CPs. This is because we are directly engaging them for this process. And then apart from the paper-based tool that they use, which we've already supported the government to utilize, government to produce and develop and then produce them, they can now use this whole system of the the digital system to at least be able to translate this data into that digital system. And then we can, of course, be able to utilize it for decision making over time. And of course, since the HIS is interoperable, we'll be able to at least use the data that we already have and then still be able to utilize it when the CHMIS on the HIS is fully implemented. And so back to your question, does the CHMIS application just capture the data from the PPMVs? Currently, yes, but of course, eventually, like we mentioned earlier, this will be the PPMVs, the CPs, and then the CHIPs. And once the CHMIS is fully implemented. And I think hopefully that answers the question.
Yeah, let me also just add something here. I think the question also has that second part that says, do they use it while assessing and treating patients? So the tools also have like the source document, which is the sick child recording form. And the sick child recording form is also used while assessing and treating the client. So from the sick child recording form, the PPMV transfers the information to the CHMIS tool. So there is that source document that is used while assessing and treating clients.
Great. Okay, so the next one, are tools translated in local languages, taking into account that most community health workers and PPMVs are illiterate or maybe don't speak English? Tosin, can you speak to that?
Okay, so currently the answer is no, it wasn't translated. And of course, it's a good one because looking at some of the implementations or some of the few interventions we've had and how we've at least translated some tools to local languages has really helped in a way. But this is a good take home as well, which I think going forward is one of the recommendations that could be incorporated into the tool. But currently, as it is, we just train the PPMVs and CPs that we engage. Not apparently, we have more PPMVs and CPs in all the states that we're intervening, but then the few ones based on recommendations that we had, we engage them. And I think, at least from what we've had, it's not really been that difficult. But of course, going forward, I think having a local language translator would be a good one. Thank you.
Great. We've got just one more statement, which is that putting the spotlight on the data collected at the community level is an interesting idea. So, yeah, and I mean, I think it's also a very, very pivotal time given the fact that the government is now really invested in rolling out the CHIPS cadre as well. And so I just think that this really is a pivotal time, I think, for Nigeria in terms of opening up what possibilities there are for community health, which is so critical to reaching remote and underserved areas. So we've covered our questions. I don't know if anybody, there's a new question. Follow-up question to Chinwoke's response to sustainability. I'm curious to know why PPMVs don't continue to collect data. Is it because they lack access to the tools or because they lose interest after the project ends?
So data collection or data recording is not, it's also tedious. It's not easy. And remember, these people are already there. They are business people. They sell medications and they haven't seen the need to keep doing this. And that's why they always ask us, what is in this thing for them? So it's not just about having access to those tools. It's them seeing the reason why they should be doing that. And that is why we're, asking the government, can there be a policy to mandate the collection of data from them, knowing that, the data from them can also inform decisions around the health of the community, or decisions that policymakers would make around the health of the community. So it's not just, it's a lot of work to record each client that comes to you. So they need to see the need, they need to see themselves as part of the health system, and they just need government support to do these things.
Good. So we just have about 1 minute left. So very quickly, I think this one is for Dr. Zainab, unless Chinwoke would like to chime in, but let's see if Dr. Zainab can take this one. So from Eric, how has this influenced the PPMV prescribing practices? For example, amoxicillin, using the amoxicillin rather than other antibiotics. Dr. Zainab?
Yeah, so as I mentioned during the presentation, immediately after the training, so even before, during the training, we brought the necessary quantities as well as how to use them. So there was practical session on how to use the commodities, which includes the amoxicillin dispersible tablets. And we emphasize on the use of the amoxicillin tablet in management of uncomplicated pneumonia in children for them. And also during the team mentoring supervisory visits, we emphasize on that. And when we found that the PPMVs and CPs were complaining of the stock out, because you are right, what they are used to is use the syrup of amoxicillin. So we encourage them to use the amoxicillin DT, which is most appropriate and more effective. We ensure that we link them off with the government drug management agency, where this amoxicillin DT is available for them to access it, and we're sure of the quality of what they're accessing. And also our sister project, that is the Promoting Quality of Medicine, PKM Plus, which have done assessment of the pharmaceutical shops that have quality medicines, and also the basic commodities that we need. They shared the list with us, which we shared with the PPMVs and CPs for them to be able to access these medicines. Thank you.
Great, thanks. We are at the top of the hour. I'm sorry that I didn't get to all the questions, but I want to thank everyone. I want to thank our presenters. I want to thank the organizers, Malia, the tech people, the interpreter. Thank you so much, everyone. I really appreciate you tuning in and hearing this little snapshot from our project. Thank you so much. Have a good day. Take care.